So a couple of housekeeping things. If you want competency hours, please, you need to stay for the entire thing, or you need to, if you go off, come back and listen to the recording. Remember to mute, and also you may want to stop your video as it sometimes helps with reception. If you wish, you may put questions in the chat, and I will do my best to keep track of them. Sometimes that can be difficult, but I'll do that. I'm so looking forward to hearing Anthony. Anthony Velasco is a PhD candidate in the College of Nursing at the University of Colorado Anschutz Medical Campus. He currently practices clinically at Desert AIDS Project, an FQHC that provides care to underserved communities in the inland desert region of Southern California. He led the creation of a regionally recognized gender-affirming care program and was presented with the Stonewall Humanitarian Award by the Transgender Community Coalition and was chosen as this year's Johnson & Johnson Health Equity Scholar. In each of his professional endeavors, he derives the greatest joy from building collaborative relationships with his patients and partnering with his community and creating patient-centered, culturally informed, and evidence-based interventions to improve healthcare access and create structural changes that meet the unique needs of systematically minoritized communities. Welcome, Anthony.
Thank you, Jim. Thank you, Jim, Nikki, and AHNCC again for inviting me to share my work tonight. Again, my name is Anthony Velasco, and I use he, him, and they, them pronouns. So before we start with our knowledge sharing, I also like to share my positionality and contextualize my sources of knowledge. I identify as a queer person of color. English is not my first language. I'm also a Filipino immigrant and a first-generation student. As Jim mentioned, I currently practice as a nurse practitioner at Desert AIDS Project, where I provide primary care, HIV care, and gender-affirming care to underserved communities in the inland desert region of Southern California. I also serve as an advisory board member for the Center for Health Equity and the Center for Health Disparities Research. Finally, I have more than a decade-long experience working with people living with HIV and the LGBTQ plus community. And it's important to say that I draw from my experiences and my identities to really inform my work and how I create relationships with the communities I work with. Before we start with knowledge sharing, I would also like to invite all of you to tune into this exercise and prime ourselves with familiar and new knowledge. If you are wanting to opt out, feel free to do so. I think you can take care of yourself for the next few minutes. However, for those who are choosing to opt in, I invite all of you to close your eyes or lower your gaze. Take the next cycle of breaths to tune into your body and mind space. I would like you to notice any parts of self or thoughts that are coming to mind or calling for attention. If you can, if these parts are accessible, invite some aspects of self that are curious, that are open, wondering and seeking out some knowledge. From me to all of you, all aspects of self are invited into the space. As a queer community member, I would also like to take this moment to acknowledge the people from the LGBTQ plus community that have come before us to honor their lives, their contributions, and their efforts in bringing safety and visibility to our community of all generations, backgrounds, and cultures. I acknowledge that there are some members of my community who are not able to be here because of the struggles our community have faced and continue to face to this day. As we venture into our presentation, if you notice or find yourself reacting to new information in a way that is challenging, make sense of an appreciation to that part. Appreciate that it is a place of growth and a place of compassion and curiosity to any responses you may have during the presentation as new information is offered to you. I invite you to be in community with any and all parts of self that may come to life during the presentation. I support you with sitting with new or familiar knowledges that I share today. I encourage you to hold on to any aspect of self that you would like to sit beside you throughout this presentation. Hold on to what you'd like to hold on to and let go of what you'd like to release in order to sit with me today. When you're ready, you may open your eyes, stretch, and invite movement before we begin with our knowledge sharing. So while I was preparing for this conversation, I remember this article from the LA Times. Being transgender in America may be hazardous to your health. In this article, the author, talked about how transgender identity is not inherently the reason why trans people have poor health outcomes. Instead, it's really about poor access to resources and experiencing mistreatment and discrimination that places trans people at risk for poor health outcomes. This is another article that came out a few years ago stating transgender women of color have an average life expectancy of just 35 years. This article, along with the numerous stories my transgender gender diverse patients have shared with me about their challenges in accessing care, really inspired me to pursue a doctoral education to understand how stigma shapes primary care access among transgender and gender diverse people. While also preparing for this conversation, I was reminded about my own transformational learning journey. I went back to my reflexive journal, which is something I started when I entered my PhD program. My reflexive journal served as a research diary of sorts where I jot down ideas, but most importantly, it was a place of reflection, of growth as a nurse scientist. This was an excerpt from my reflexive journal entry from September 9 and 10, 2022. A few months ago, a stranger sitting beside me on my flight back to Palm Springs saw my Pride Rainbow shoes. In a loud and aggressive voice, he asked, "Do you have AIDS? Do you have monkeypox?" I remember fearing for my safety throughout the flight. I remember keeping quiet and thinking, ignore and do not engage. While others heard what the stranger asked me, no one intervened. I remember feeling powerless, sitting boxed in next to the window seat and preparing to defend myself if the interaction led to physical violence. So studying stigma is personal to me. Being a member of multiple systemically minoritized identities, I have personally experienced mistreatment and discrimination multiple times in my life. Experiences like this motivated me to really understand how stigma is experienced and how it shapes the experience of health and healthcare access among historically minoritized communities. It also motivated me to understand my role in creating and maintaining oppressive systems, how I can start interrogating my power and my privilege, and how I can dismantle, hegemonic systems that allow social injustice to occur. Before we dig deep into our presentation today, I would also like to define some terms. I recognize that we all come to this space with various degrees of understanding of concepts related to gender and gender identity. For some people, this may be a review, but for others, these may be unclear concepts. So to help equalize these varying levels of understanding, I think it would be very helpful to review some of the concepts we'll be talking about today. Today, I'll be using the genderbread person to define sex, gender identity, gender expression, and sexual orientation. An important concept to understand is that sex, gender identity, gender expression, and sexual orientation are not the same. So first, when we talk about sex, this refers to anatomical sex or sex assigned at birth based on someone's external genitalia. It also includes things like chromosomes and hormones someone has. When someone is born, someone could be assigned male at birth, assigned female at birth, or intersex. And again, it's not the same as gender identity. When we talk about gender identity, we refer to a person's internal sense of being male, female, both, neither or another gender. When we talk about transgender, this refers to the gender identity of a person whose gender identity is not the same as their sex assigned at birth. It's also an umbrella term that includes a variety of non-cisgender identities. And for the purpose of this presentation, I'll be using the word transgender and gender diverse, or TGD, to include all gender identities under this umbrella term. Now, when we talk about cisgender, this refers to the gender identity of a person whose gender identity is the same as their sex assigned at birth. So for instance, if somebody was assigned male at birth and they identify as male, then they would be considered as cisgender. Now, when we talk about gender expression, it's the way a person displays their gender externally. It describes how we perform our gender, meaning it is how we dress, how we act, how we talk, our demeanors, and so on. Someone's gender expression can be masculine, feminine, androgynous, or gender non-conforming gender expression. Again, it's very important to point out that someone's gender expression is not the same as someone's gender identity or sexual orientation. So for example, a person assigned female at birth whose gender identity is female may choose to dress up more masculine. This does not necessarily mean that they are a transgender man or a lesbian. So really my point is it's important for us not to make assumptions of other people just based on their appearance. Finally, sexual orientation describes how a person is emotionally and sexually attracted to another person. Someone may identify as gay or lesbian, bisexual, pansexual, or straight. So when we talk about LGBT, the LGB refers to sexual orientation and the T refers to gender identity. And again, it's very important to point out that sexual orientation is not the same as gender identity. Now that we define those concepts, let's now talk about cis heteronormativity. When we talk about cis heteronormativity, it's this dominant idea in our society that creates assumption about gender and sexual orientation. It's cis heteronormative discourse creates this assumption that everybody's cisgender and heterosexual and privileges this assumption over other identities. When I was thinking about cis heteronormative assumptions, there are some things that came to mind. So for instance, there's this assumption that there are only two genders, right? Being male and being female. This assumption erases other gender identities, especially those who identify as non-binary. There's also this assumption that sexuality is static. And for many people, sexual orientation is unchanging, but this is not necessarily true for everybody. Another assumption that I think about is that gender dictates sexual orientation and attraction. So again, for example, people may assume that just because an individual identifies as a transgender man, that they are only attracted to women. It's possible that transgender men may also identify as gay and therefore have relationships with other men. Here's another one that I heard recently. There's this assumption that all trans people want to transition all the way. We know that there is no one way of being trans. And what does transition all the way even mean, right? Some people may want to pursue, social transition or medical transition or surgical transition or legal transition, but some people do not desire to be on hormones or have surgeries or other ways of quote unquote transitioning. Finally, there's this assumption that how one presents their gender externally automatically dictates their gender identity or sexual orientation. And as we discussed earlier, there are different concepts. These are different concepts that are not mutually exclusive. So I'm curious to hear from some of you, what other assumptions have you all observed in the community or in healthcare settings? So when you think about about cis heteronormative assumptions. Um, in the community, for instance, what one of the things that we see in the mall are those gendered clothing and toy sections in the mall. Oftentimes they're separated, boys section, girls sections. What other things have y'all seen in the community or in your own practices?
I think, well, you mentioned fashion. I think if we think about fashion, we think of, a cisgender woman only being, being very feminine as they dress, or a man being very masculine, only wearing flannel and jeans or a suit, as opposed to, and dark colors as opposed to wearing pink or things like that.
All right, thank you, Marcy. Yeah, that's a really great example. How about in your places of practice? How do you see cis heteronormative assumptions manifesting in your practice?
I was going to say one of the challenges that we have in the jail and prison system are assumptions that persons that are coming in that are not cisgender are assigned to go into the male side or the female side. And that's right now causes for some of the security folks and even some of the nursing folks agita as they try to figure out where someone should be. And we've tried hard to say it's not how they present, it's a good discussion with the client, with that inmate, to talk about what they're going to be comfortable in and which, if you will, side of the jail they're going to be comfortable and would be safe in. That's
Mhm.
the other thing that is our responsibility in that jail prison setting is where will they be safe?
That's a really, really challenging situation for many trans people. There has been some studies that have been published recently about, transgender women in particular in the jail prison system, where there's a lot of fear for violence. There was one study where some trans women have stopped transitioning, meaning they stopped taking hormones and they started appearing more masculine again. And this is to prevent potential violence if they were, placed in a quote unquote male area of the prison jail system. So that's a very good example. In healthcare settings, I also think about, forms that does not separate sex and gender, or even forms that limits options gender to two options of just male and female, and not allowing, patients to really identify the way that they do. When we talk about decentering from this cis heteronormative assumptions, it allows us to question the power structures that exist in our society. It's very important for us to decenter from these assumptions because they are harmful to all of us, including those who are cisgender and heterosexual. And I think it's very important for us to acknowledge how these assumptions exist. Also opens a conversation about the historical and social context that shapes how we see gender and sexual orientation, especially here in the US. So at the root of this cis heteronormative assumptions, we will see that, power imbalance is at its core. Those who identify what it is to be, cisgender and straight often occupy dominant spaces, and those who are not, meaning those who are not cis or heterosexual, including transgender and gender diverse people, are often forced to occupy the margins. These power imbalances and cis heteronormative assumptions are seen when we explore the experience of stigma among trans people. So in my preliminary work on stigma and healthcare access among trans people, I also learned that trans people experience stigma within and across various socio-ecological levels. At the individual level, trans people experience stigma through a psychological process shaped by how they perceive themselves and how they are perceived by others. So for instance, they experience anticipated stigma, and this is manifested as fear that they will be exposed to mistreatment or violence when accessing care before it actually happens. Oftentimes, this anticipation often leads to isolation and marginalization. Trans people also experience internalized stigma through a self-application of negative feelings and beliefs based on their gender identity, which often leads to shame and prevents people from accessing care. But one thing to point out is that despite these barriers, we have this very important finding that trans people challenge stigma. And trans people challenge stigma by being strategic who they disclose their identity to. They foster self-agency by advocating for themselves and others when navigating care. They often do this by avoiding healthcare organizations and providers who are not gender affirming, or by being, assertive in setting boundaries from others to avoid stigmatizing situations. They also build a community, a coalition with other TGD people and allies. What's also interesting, some people challenge stigma by conforming to their cis heteronormative environment. And like what I mentioned earlier, an example with the prison system where some trans people, to avoid being stigmatized, they conform to the cis heteronormative environment. Others, they amplify the gender expression to challenge the stigma. Trans people also experience stigma at the interpersonal level. And the most common form of interpersonal stigma is verbal abuse, such as being misgendered, being dead named, and being exposed to discriminatory and demeaning language. When I talk about being misgendered, this is using a pronoun that they don't use for themselves. When I talk about being dead named, that's calling somebody by the name that they had in their birth certificate, even though they don't use that name anymore. What we also found in this literature review is that trans people are often stereotyped as someone living with HIV, even when they are seeing HIV preventative services. Many trans people were also concerned about privacy, confidentiality, and breach of trust, particularly when they are disclosing their trans identity, about their hormone use, about their surgical history with their healthcare providers. What's really sad is that medical violence was also oftentimes reported by trans people in healthcare settings. And this includes sexual violence or being forced to take medications that do not align with their gender affirming goals. Finally, denial of care was also very commonly reported among trans people. Finally, our findings show that trans people experience structural stigma when accessing care. Trans people report that they have to teach their healthcare providers how to properly treat trans people. Those who does not meet cultural gender norms of what it is to be, masculine or what it is to be feminine, are often aggressively questioned about their gender identity. Oftentimes, they are not believed what their gender identity is. Trans people also experience systematic barriers to care, such as insurance-related barriers and experiencing difficulty finding clinics and healthcare providers that are affirming. I'm sad to say that I have patients who live 3 hours away, who travel just to seek care here where I currently work. I'm so proud that my organization now provides telemedicine, where we're able to see people who live really far, and we're in the process of really expanding our program to a bigger geographical area, so that way we can provide better care for our patients. Finally, the pathologicalization of gender identity creates barriers to trans people. So for instance, trans people need the diagnosis of gender dysphoria to access gender affirming hormones and surgeries. We also know that stigma shapes the health and healthcare access of trans people. So for instance, in 2016, the National Center for Transgender Equality published the 2015 US Transgender Survey, This was a landmark survey of more than 27,000 transgender and gender diverse adults in the US. What this report saw is, clear patterns of mistreatment and discrimination in several life domains, including access to healthcare services. For instance, according to the report, trans people experience several health insurance and healthcare-related issues. 1 in 4 of trans people reported experiencing insurance-related problems in the past year. So this includes being denied coverage for necessary and appropriate care related to gender transition, or being denied coverage for routine care because they were trans. Of those that reported insurance-related issues, 55% were denied transition-related surgeries, and 25% were denied hormone therapy. It's also very disturbing that 1 in trans people reported having at least one negative experience with a healthcare provider. This includes physical abuse, verbal harassment, sexual assault, and being refused care by a healthcare provider. What's also sad is that this is even higher among trans people of color and those with disabilities. It's no wonder why 23% of trans people did not seek medical help when they needed to, because of this fear of being, mistreated just because of their transgender identity. When we look at mental health, 39% of trans people reported experiencing serious psychological distress. And in comparison, only 5% of the US population have reported experiencing serious psychological distress. 4 in 10 trans people also have attempted suicide in their lifetime. In comparison, only 4.6% of the US population have attempted suicide in their lifetime, which means that, trans people are 9 times more likely to have had lifetime suicide attempt history. 7% of trans people also attempted suicide in the past year. In comparison, less than 1% of the general population in the US have attempted suicide in the past year. Trans people are 12 times more likely to have had suicide attempt in the past year compared to the general US population. I had to update my slides in preparation for our discussion today. Just last week, just a few days ago, the National Center for Transgender Equality released the early insights from the 2022 US Transgender Survey. The 2022 survey had more than 3 times the number of respondents, and they included 16 to 17-year-olds in the survey. Unfortunately, we remain to see high levels of mistreatment and discrimination that poses significant challenges for trans people in all facets of life, including access to healthcare services. So for instance, 26% reported insurance-related issues, such as being denied hormone coverage or even preventative care services. In the 2022 survey, almost half of all respondents reported experiencing at least one negative experience when accessing care. And again, in comparison, in the 2015 survey, 1 out of 3 reported, and now almost 50% have reported experiencing at least one negative experience. Almost a quarter also avoided seeing a doctor even when medically necessary, to avoid mistreatment and discrimination. And sadly, more people have reported experiencing serious psychological distress compared to the 2015 US survey. In our systematic review exploring health vulnerabilities of trans older adults 50 years and older, we found that many of these health disparities were also more pronounced. So for example, when we talk about access and quality of care, we found that 20% of trans older adults did not have a primary care provider. 9 to 11% of trans older adults also did not have a medical checkup in the past 2 years. 42 to 49% avoided preventative care, such as receiving recommended immunizations or cancer screenings and bone density scans to assess osteoporosis. Almost 35% of trans older adults also has not disclosed their gender identity to a healthcare provider, due to fear of being mistreated or being stigmatized. We don't have an actual number of older trans people with certain chronic conditions, but based on some studies included in our systematic review, older trans people have high rates of having multiple chronic conditions, diabetes, cardiovascular diseases, and asthma. Trans people also have high rates of cigarette smoking and substance use. For instance, about 26 to 29% reported smoking cigarettes. Approximately half of older adults also reported ever abusing illicit or prescription drugs sometime in their life. And about 21% of older adults reported heavy drinking in the past year. Regarding mental health, 48 to 55% had clinical symptoms of depression, but up to 80% of participants in some studies reported loneliness and isolation. About a quarter reported a history of suicide attempt in the past year. And this is, significantly higher than the suicide attempt rate among all trans people, which was 7%. This shows that trans older adults have much higher rates of suicidality. What was also troubling was that many of the studies included in her systematic review reported that many trans older adults mentioning suicide and euthanasia as a means to avoid discrimination and mistreatment if they cannot take care of themselves or if they are forced to live in long-term care facilities such as nursing homes. Now that we've talked about stigma and how it shapes health and healthcare access among trans people, I think it's very important for us to ask how can we, as nurses, address these health disparities. It would also be important to understand how nurses engage in social justice. So when I was exploring the nursing literature, it was very challenging to find a nursing theory of social justice. While social justice is central to the discipline of nursing, it was also vaguely defined. It's important to know that a social justice framework in nursing is, essential for us to understand how nurses experience transformative learning process when we engage in social justice. It can also allow us to challenge conventional nursing by constructing new pathways and understanding the role of nursing and social justice. And finally, a social justice framework can, help guide the nursing practice, education, research, and policy. So in my search for a social justice framework in nursing, I found this theory of emancipatory nursing praxis published by Dr. Robin Walter in 2017. This theory describes the transformative learning process that nurses undergo when we engage in social justice. To the right is a modified visual representation of the theory. The theory consists of 4 conceptual categories and 2 contextual categories. Dr. Walter used this quantum spiral to describe the continuous motion, growth, and evolution of how nurses engage in social justice. And for today's presentation, I really want to focus on the 4 conceptual categories because this describes the transformative learning process of nurses engaged in social justice. This will also allow me to share my own transformational learning process as I engage in social justice. So the first conceptual category is becoming. At this point, nurses are largely unaware of their privilege, their social position, and the root causes of social injustice. This includes earliest memories, often shaped by our interpersonal characteristics and environmental factors. Becoming reminds me of this passage from my reflexive journal entry dated May 16, 2021. Writing my self-evaluation paper for Nurse 7220 and contemplating why I wanted to study stigma among trans people made me engage in what was a difficult and uncomfortable process of critical reflection. I reflected upon my experience as a queer kid growing up in the Philippines, remembering being called gay at a very young age, even before I knew what gay meant. I remember being bullied throughout primary and secondary school for being too soft, too feminine, and too flamboyant. I shouldn't have experienced that. No one should. At this point, I had a basic awareness that something was not right and that something must be done. Dr. Walter described awakening as either an inflection point or a process that developed over time. It is described as a juncture where there is a shift in our worldview, and it starts to occur with that juncture. At this point, we, self-examine our beliefs, attitudes, and assumptions. We have dialogues with others who hold different beliefs or experiences. We break down previously held beliefs and continuously challenge our new worldview. For me, my awakening was a series of significant events that shifted my worldview. This passage was from a journal dated April 26, 2022. Several years ago, before deciding to pursue doctoral education, a conversation with a trans-identifying colleague resonated with me so well. They said, when I ask researchers and scientists who study trans health why they study our community, they say the same thing. I'm doing this kind of research to give trans people a voice. That response drives me nuts. They assume that we don't have a voice. They assume that they can speak for us. We are not voiceless. They just need to hand over the cat mic. Engaging is a dynamic and interactive process of achieving transformative goals. At this point, nurses engage in reflection leading to action, dismantling power imbalances, collectively responding to social injustices, and persisting to engage in social injustice despite personal, professional, and financial risk. I firmly believe that nurses are strategically positioned to partner with patients and the community in developing and implementing interventions that move away from coping with unjust conditions to actions that facilitate liberation from oppressive structures and systems. Being an ethically responsible nurse scientist involves advocacy, public health education, and leading policy changes. It involves continuously engaging in self-evaluation of privilege and position in the nurse-patient relationship. Dated May 18, 2021. Doing the work that I do, I realize that engaging in social justice is not confirmed within the four walls of the clinic. I partner with my community in developing programs to improve healthcare access for trans people in the Inland Empire. I collaborate with university and community-based researchers in developing and evaluating interventions for health conditions that disproportionately affect trans people. I share my expertise with policymakers so they could make evidence-based decisions when proposing legislations that affect my patients and how I provide care to trans people. These activities are ongoing and always in partnership with the trans community. Finally, the fourth conceptual category is transforming. At this point, there is an expansion of consciousness where our thoughts, our feelings, and actions are reconditioned as a result of engaging in social justice. It's also important to understand that this is an ongoing process with the goal of achieving human flourishing, equity, and transformational social relationships. Now, there are two contextual categories, relational context and reflexivity. Relational context includes individuals, groups, organizations, institutions, community, state, national, international, and global context. The original model by Dr. Walter does not explicitly include stigma. However, in my previous work on stigma and healthcare access among trans people, it was evident in the literature that stigma operates within and across its various contexts. What's very important to understand is that nurses can be an agent for social justice within and across its various relational contexts. The second contextual category is reflexivity. Dr. Walter described reflexivity through its four dimensions: descriptive, self-aware, critical, and emancipatory. what is important about reflexivity is the need for critical and emancipatory reflection. I think nurses must continuously challenge our worldview and deconstruct our assumptions, feelings, beliefs, and biases. It's also important to know that, reflection without action is ineffective. Therefore, we must engage in social justice by addressing these health disparities. So now that we've talked about the theoretical framework of how we can engage in social justice, how do we apply this in nursing education, practice, policy, and research? So in nursing education, we can take several concrete steps. First, we need to be intentional in reforming the nursing curriculum to better prepare students in caring for trans people. There was a study that came out a few years ago by Dr. Lim where he surveyed nursing schools in the US and Canada. And if you could guess how many hours in the nursing curriculum are dedicated on LGBTQ plus health, how many hours do you think is dedicated for LGBTQ plus health?
Less than one.
I'm sorry, say that one more time, Marcy.
I was thinking like less than one or maybe 1 hour at most, but probably less.
Very close. On Dr. Lim's study, it was 2.2 hours in the entire nursing curriculum dedicated on LGBTQ plus health. In another study that came out just a few years back where they surveyed medical schools in the US and Canada, they found that the median number of hours dedicated on LGBTQ plus health related content in the entire medical curriculum was just 5 hours. So we have a long way to go. I know that many schools are really integrating LGBTQ plus education in the nursing curriculums. But it's very important to know that, trans health topics should be infused throughout the nursing curriculum and not just a one-time guest lecture or as an elective course. It has to be integrated in pre-licensure and post-licensure programs. Second, we must ensure that our foundational nursing documents published by nursing professional organizations include social justice as one of its core values. Third, we must collaborate with the trans community in educating and training nurses. The findings from my preliminary work on this topic show that, trans people want to be involved in educating nurses. Working with trans people can really help shape, working with trans people can help us learn about their experiences of stigma and really contextualize the role of social justice in nursing. But what I would also like to add is that if nurse educators are facilitating, these types of education and training, it's also important to acknowledge that doing these kinds of presentations has associated emotional labor. So I think it's important that we compensate trans people for being an expert of their lived experiences. We can also use simulation-based education to give nursing students an opportunity to have real-time interactions with virtual trans patients. I've used clinical reflections with students to discuss and integrate didactic learning with practice reasoning when we talk about trans patients during our post-clinical conferences. I think these steps can help us improve communication skills, cultural sensitivity, and self-reflection. In nursing practice, we can create self and affirming spaces for everyone. We must, establish policies that protect gender identity and expression, using inclusive language, sharing pronouns during introductions, and dispelling assumptions about gender and sexuality should also be an ongoing practice in all institutions. In practice, we can also standardize a collection of sexual orientation and gender identity information for all patients, regardless of their sexual orientation or gender identity. Our medical records should also be inclusive to allow everyone to indicate their chosen names and pronouns. We can also have accessible bathrooms for everybody, regardless of their gender identity. I think it's also important that we diversify the nursing workforce by creating mentorship programs and creating pathways for advancement. And finally, we should foster community engagement in inviting a diverse group of people in community advisory boards in our organizations. In policy, we as nurses have so much we can do. As of this week, there are 432 anti-trans bills that have been introduced across the US. These bills block trans people from receiving basic health care, education, legal recognition, and right to publicly exist. So how can nurses address this? First, it's important for us to remember that public policy is really within the realm of nursing. When we go back and think about what we do as nurses, it will become clear that nursing is inherently political. Public policy influences how we practice and how we provide care. We must be reminded of the relational nature of nursing and how we can leverage this in partnering with our patients and our communities to create positive social change. It's also important to remember that nursing is the largest healthcare profession. We can advocate for trans people by working with our professional nursing organizations in creating amicus briefs and policy reports that target policymakers. We must also educate ourselves about trans issues and legislations. And we can do this by working with our local trans community partners and amplifying their voices. And frankly, professional nursing organizations should pursue legal action in response to legislations that limit our scope of practice or those that criminalize providers for providing evidence-based care to trans people. Doing research on this topic can also provide important information needed in engaging in creating evidence-based policies and protecting the rights of trans people. With my preliminary work on this topic, I also found that the literature on trans people is very limited in nursing. When we look at healthcare access, there's also very limited literature on how trans people experience stigma, especially in the primary care setting. There's also an overrepresentation of trans feminine participants in trans health research, which means other trans identities, particularly those who are trans masculine or non-binary, are under-researched. Most research on trans people are also focused on trans youth and young adults, which makes trans older adults underrepresented in research. Finally, there is a lack of research on transgender aging, particularly on the cumulative impact of stigma on trans older adults and the relationship between stigma, concealment of gender identity, and delay in accessing care among trans older adults. Addressing these gaps are critical so we could develop evidence-based, person-centered, and culturally informed interventions to improve healthcare gaps among trans people. Now that I've shared some concepts and theoretical framework to help contextualize the knowledge shared today, I'm interested to open our conversation and learn about how you would apply these concepts in your own practice. So let's start first with this conversation starter. Given the current social political climate that calls for social justice, how can we actively engage nurses and nursing students in social justice?
Anthony, this is Margaret, and I'm in a state that's almost a dictatorship in Texas because this is not even something that is allowed. Anything that has anything to do with diversity, equity, social justice is illegal within the state system, within the school systems. And what comes to mind with this question that you're asking is we have to do it one person, one action, one word at a time. as a beginning, because we can carry the message, we can show others how we present on these issues. Um, for us here in Texas, it is very, very difficult to have things like this introduced in the curriculum without people being fired, losing their jobs, etc.
Right, that's a very good point. I know that in Florida, for instance, you know, there is a legislation that just got passed, well, a few months ago, where it's it's illegal for nurse practitioners and physician associates to prescribe gender affirming hormones. They have to see a physician, or um, it does not allow nurse practitioners and physician assistants to provide gender affirming care via telemedicine. It also prevents us um, from providing care for trans youth. So it's very challenging when the place where we work or the place where we practice prevents us from really exercising our full scope of practice.
And I am not saying that we don't do what you're asking. I mean, the question here, I'm saying that we have to live the beliefs and the values. We
Mhm.
have to engage our colleagues. We have to engage our students in these actions, even when we are prevented from having it in the curriculum. Officially in the curriculum, you can
Mhm.
still talk about respect and honor of people's cultural values, beliefs, worldviews. And so maybe it is more challenging, but it isn't impossible. You may have to watch the language you use, but I think that one of the biggest problems in nursing and in healthcare is that if people aren't heteronormative, cisgender, white, um, middle class, so many things, considered able, um, et cetera, are assumptions made and they aren't given the respect and treated honorably in the actions, in the healthcare actions. And there's no reason that as an individual nurse, as we are working with our colleagues and our students, that we can't stand up and do what is right.
Absolutely. We just have to be very creative in how we teach and share how it is to engage in social justice. I do have a colleague who practices in a state where a lot of restrictions are in place. And the way that he's able to do this is by having his students as an assignment do write an opinion editorial, submit an opinion editorial on climate change or something that's not related to gender identity or sexual orientation, submit it to a local newspaper, like doing an editorial. Even though they're not explicitly doing an editorial on, gender identity or sexual orientation, that exercise gives the students the tools and the experience of how to engage in social justice in many different ways.
There was one comment, Anthony, in the chat. I think talks like this, and as you have mentioned, mentors like yourself as content experts. So many of my colleagues feel confused about how to support, approach, and even address TGD patients, which is sad.
Yeah, thank you for that comment, Karen.
And then
Yeah,
Vita's hand is up also.
um, go ahead, Ida.
Well, first things first, Anthony, this is wonderful, and I appreciate your expertise and your time, and that you are engaging in research that can now be available to support through educational opportunities such as this and other educational avenues. Excuse me. So when I look at this question, I think education always is key. Nurses, I mean, every nurse that I know and that I teach, because I'm also an educator, understand the value and the importance of evidence-based research. And so as we provide that for them, in whatever avenues we're teaching or working, that to me is key. It's like, can we like leave articles that you've written around in the nurses station, you know, something of that nature where there's visibility and nurses value it. They don't always know how to get their hands on it. In addition to that, clinical nurses at the bedside often are not necessarily research-based. So part of our role is to demonstrate that for them. In my experience, I incorporate a number of the things that you've presented today in my teaching. I have to do, my work is more along the lines of, it's not academic, it's continuing education. And so I create an opportunity in a communication class to bring up this very important topic that a lot of nurses have not even considered before. But in that, every single time I present the sort of the broad brushstroke of the concepts of trans people, I open the dialogue to incorporate anyone who may have a story or an experience or what have you that can then make it real. And I was teaching just a couple months ago in Pennsylvania, and as I was presenting, I opened the dialogue, and two individuals, two nurses in the cohort, the community, they each had children who were somewhere in a transitional process in their own, you know, in their own journey. And the beauty of that was that it made it real for the other 30 people in the class. It was like, wow, you know, this is not just something that we may experience someday or maybe never. It is real. And the way that these two nurses presented their stories, you could tell that the community members were so moved by it and then awakened as a result of bringing it into a real context, not just something that you can read about in a book or in an article. So I think that the combination of education and story becomes so important as we help nurses awaken using Walter's. I wasn't aware of her theoretical, her middle range theory, and I really appreciate that. I'm gonna do some reading about it. So yeah, I think between education and making it be real with story can be very, very helpful in helping nurses to awaken to a whole other level of this work. But thank you so much today. I appreciate it.
Thank you, Ida, for sharing that. I do agree. Stories are very powerful, and that's what's drawn me to using narrative inquiry in my own research. So my research uses Reisman's narrative inquiry, where where I amplify people's stories, their stigma narratives, to really understand how stigma shapes their experiences in healthcare settings. I think we also have a question on the chat from Teresa. What do you see as a driving force in such states as Texas and Florida? Is it a lack of knowledge or religion or other? That's a very good question. I think it's multifactorial. I think, again, it's rooted in cis heteronormative assumptions. It's rooted in patriarchy. It's rooted in cultural gender norms. A lot of these things, I think, intersect that creates this oppressive system and structure that prevents trans people from accessing care or from from having quote unquote the same rights as the general population. I think it's multiple factors. My next question for the group, how can nurses drive change in systems where equity and inclusion are not priorities?
Anthony, it's Margaret again. And I'm currently in a couple organizations where they kind of think it's somebody else's problem. And I just kind of find that I think it's helpful to keep being a burr under the saddle and keep poking away at it. And I'm going to stop because we have two hands raised. The first is Lori Roses, and then the next will be Candace.
Well, I liked what you said about being the burr under the saddle, and you know, always like getting on boards or being involved in you know, various community things. Of course, you know, that's open to nurses, but you know, everybody doesn't want to do that. But on your own unit or in your own classroom, you can make those a priority, and you can keep your eyes open for instances where you can be the burr under the saddle, or even the salve on the saddle sore. And I just think it's important to keep it in front of your own face, so you act the way you want.
Thank you, Lori. Go ahead, Candace.
Thank you for your presentation, Anthony. I enjoyed it a lot. There is I have a larger comment, but one slide I would like some clarity on. I don't know which slide exactly it was. It was one of your reflexive journal entries about the scientists who responded that they were doing the research to give voice to people who are trans. And then the ending of the quote was, you know, goddamn, we already have a voice. So could you speak to that a little bit? And then I have a second, probably a larger comment.
Yeah, so this conversation I had was actually one of the driving forces that propelled me for doctoral education. So basically what, just to kind of rephrase this a little bit, I was having conversation with a trans-identifying colleague, and they mentioned to me that when they ask researchers and scientists who study trans health why they do trans health research, oftentimes nurse researchers or scientists or researchers always say, you know, I'm doing this kind of research to give trans people a voice. And their response to me, my colleagues' response to me was, you know, it's not that they are voiceless. Oftentimes researchers assume that they have to speak for trans people from the research, but that's not always the case. This reminds me of this concept of choke silence by this African feminist author. Her last name is Kunyoro, and she talked about this concept of choke silence when you have a voice but you're not being heard, and that's basically what this passage was about. It's about, you know, people assume that trans people does not have a voice. When they do have a voice, it's just a matter of us as nurses, as researchers, as scientists, to hand over the mic so that we can amplify those stories, those voices. Does that help answer your question, Candace?
Somewhat. I think this would be a topic, this one slide topic, something that maybe you and I could talk about at length, because I don't want to take over so much time. I do have some comments. I myself have a disability and relate in a probably different way than another person. Anyway, thank you for that response and clarification. Could you go to the question we're on now at the end about social justice and what nurses can do? My nature is to be a burr under the saddle. And I have found now that I'm 70 that it doesn't really work. That people don't like burrs under their saddle. They get off the saddle and they walk to the saddle that doesn't have a burr. So I'm finding that the burr doesn't, that the analogy of a burr, Mickey, doesn't help in the outcome we're aiming for, which is equity and inclusion. It doesn't mean we give up. It doesn't mean we give up our voice, our desires, our wishes, our all the things. I can't even list all the things. So don't get me wrong. I'm still caring about all the equity and inclusion that needs to happen. What I am finding that works best so far in my 70 years is that if we can get to what is similar in all things, in people, you know, we're starting with we are all human beings. How about that? What is similar? What are the basic needs? Think Maslow. You all know Maslow. Food, air, water, shelter, blah, 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 loving and self-actualization. That will be hard for a legislator to say, no, we don't care about that for human beings. So if we stay in, this is my experience, if we stay in we are all human beings, it's hard to say, no, you're not. If we stay with we all need food, and you know that's a problem, still a problem in the world and in our country and in my state. If we stay with basic needs, we are on more of a starting ground where people can hear. The people who don't want the burr under the saddle can hear better, my experience is, with a starting point of what is the need of any human being of any age related to equity and inclusion. It's hard to say that a human being cannot be included, different than all the categories of difference: race, transgender, disability, male, female, women, blah, 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 blah. We are, yeah, thank you, Margaret. So that's my input, that yes, we need to stay with it. You know, the American Disabilities Act is old now, and we're still working at including, I mean, when's the last time you, in any of your experiences as nurses, you saw a nurse actually working in one of the various nursing roles who had a disability, visible or not? When's the last time you saw that? It's not too often. So think big picture, please. Basic human needs, Maslow, and we are all human beings first. Thank you.
Thank you for sharing that, Candace. I think, you know, it's important for us to see what makes us all the same, and then yeah, we all have the same needs, and we all want to thrive, you know, in our lives.
Yeah, we have Marcy, and then there was a comment from Kathy.
Go ahead,
Yeah.
Marcy.
Okay, so thank you so much, Anthony. I wanted to give a more specific example, but echo what Kansas was saying at the end, which, because I used to work nights on a unit that even, that a lot of the staff had never encountered somebody who was gay or somebody who was trans. And you know, number one, I would just lead by example, treating them as a human being. And I would also talk with the staff about finding, you know, about helping them realize that they're a person, they're human. And I remember one of the nursing assistants came over to me and said, oh, he's very nice, you know, and I said, well, why wouldn't he be? He's, just a lovely person. Oh, yeah. It was you have to start small sometimes, just helping people see where a person might uh, be someone who they can relate to or have a conversation with, because they're probably intimidated and uncomfortable because it's against their religious background, or it's just somebody different from them that they've never met before. I used to be the person that everybody would come to me with Jewish questions because I'm Jewish, but I'm not religious. And they felt uncomfortable asking people who are more religious about, how do I treat this person, or why are they acting this way? And I know enough that I could either answer their questions, or I had people I could call to find out the answers so I could help educate the staff about that. And I'm kind of viewing this as similar. It's another way that people are different, but there's more that's similar about us. There's more humanity that connects us than divides us, if we allow it to give us a chance.
Absolutely, and I'm so glad to be invited and share this space with all of you and really start to have this conversation so that way we can really highlight how, the similarities amongst us. Thank you for sharing that, Marcy.
We had a question from Kathy that asked if the presentation, if we were able to get a copy of the slides. Some people would like to bring them back to the institution. And then Mickey reminded us that we'll be closing soon, so we can refer those persons to the recording, because if you didn't hear the beginning, it might be important for you, especially with the slides, because it helps you to get to this point where we are now.
So thank you for that, Jim. Yes, I'll be more than happy to share my slides. I'll send it to Jim and Mickey, and I'll be more than happy to share the slides with all of you. Any other questions for me before we close?
Anthony, I need to say that I really appreciate Candace's comments. When I talk about being a burr under the saddle, I think that old saying about loving people, killing people with kindness. And somebody said to me after they'd been known me for quite a while, you didn't ever let it go. You came at it from different ways and different perspectives, and I finally was able to hear what you had to say. So I think that if it's truly, if we are really a pain in the patootie for someone, then the natural response, Candace is right. They want to get away from it, like they change horses, etc. But I think that the persistence, I think normalizing that we're all in this together, that we're all human beings, we all have the same basic needs, is really important. But I also think it's staying with, I don't want to say the agenda because that sounds so cold, but staying with, we're all in this together. We're all human beings. We all deserve respect and being honored, and not letting it go, because it does get very tough. And everybody on this call has probably experienced the feeling of swimming upstream as a salmon. And we just keep going back at these things that need to be changed in a little different way, but always doing it as respectfully and as kind as we can. Because if somebody gets on the defensive, Candace is right, they're gone.
And we
Yeah.
try to avoid the bear. We've had a couple people have asked about how to access the recording. I don't know whether Ray or Mickey want to respond to that.
It will be on within the next couple days. It will be on our YouTube channel, and there is a conversation corner link on our website. I believe that it is on the EEDIBSJ page. as one of the resources. All of our conversation corners except the first one, where they asked not to record, are available for you to listen to at your leisure, share with others, etc.
There are a couple other, I don't know whether we want to read all of them. Helen said, thank you, Anthony, HNCC. It's an important topic. Appreciate participating and happy to know there will be a recording we can refer to in the future. Namaste. And then Mary Beth said, I'll go just down to the bottom one where she says, I also think it's important to vote. And to become a member of a national nursing organization or your particular nursing organization that you think that you are a member of. It's important because you have influence as then a member to change that. And as Anthony had talked about earlier, we have a scope of practice and there are legislators who are changing our own scope so we can't practice as we have been taught.
Jim, read Teresa's note too, because it is a positive note.
Oh, okay. Positive note, UVA has a clinic for transgender patients.
Need more. I'm glad that there's more and more organizations that are doing that. Thanks for sharing, Teresa.
Can you hear me?
Yes.
Okay, I think the other significant thing, I don't know if everyone knows what UVA is, but it's the University of Virginia. And politically, we're kind of purple. We switch back and forth. But my point in this is that for a university hospital in the middle of Virginia, rather than the north where they tend to be more open, it is very significant for there. And I mean, it's just wonderful. And we, while I was still practicing there, we brought a plastic surgeon in who his specialty is doing all the surgical interventions for people who wish to switch. And I had the honor, and I do mean honor, of caring for some of those patients. And, you know, I wish people that were so prejudiced against them could see, you know, the delight and the happiness and the relief in their personalities, because they were able to, for once in their life, have what they wanted and felt inside that they needed. And so it's amazing, you know, to do that. But I agree with Jim, we need more of those in around. And Anthony, thank you.
Thank you, Teresa. Yeah, I mean, really, if you think about it, doing the work that we do is a form of social justice. I've received nasty emails, voicemails for being a nurse practitioner that provides gender affirming care, for providing evidence-based practice care, like providing nursing care for trans people. I've received death threats for doing that. So, you know, being able to continue to do what I do and having an organization that supports what I do to be able to provide that care for my patients, I think is, you know, is one way to engage in social justice.
And Mickey said, it is hopeful, one step at a time, always moving forward.
Well, my last slide, I'm gonna, instead of having it as a question, what I would like to urge all of you is to bring back what you learned from today to your places of work and places of learning, so we can better address health disparities among transgender and gender diverse people. Again, thank you so much to all of you for inviting me in your space. And I hope that you found resonance with our conversation today. Thank you, everybody.
Anthony, we are getting multiple thank yous to you for the presentation, for your eloquence in speaking and the slides. So we truly want to thank you for being willing to be the voice and to be a voice this evening.
Thank you. Thank you again, everybody.
Thank you. Thank you so much.
Everybody have a good night. We thank you